At the outset, I would like to thank CIPLA for arranging this wonderful seminar on I will rather call it a wonder drug, N-acetylcysteine, and which is now playing a very important role in the current COVID-19 crisis as well. What I plan to do is I want to start with a basic definition, little bit of biochemistry about what is the free radicals, what is meant by oxidative stress, what is the importance of antioxidants, and then we move on to the role of N-acetylcysteine as an antioxidant in COPD, viral infections, and then end up with a COVID-19. So to begin with, what is oxidative stress? See, oxidative stress is nothing but an imbalance of oxidants on one side and antioxidants on the other side in the body. So if this imbalance occurs, more of oxidants are produced and this leads to cell and tissue damage. Now, under normal conditions, cells are able to balance the production like a seesaw between the oxidants and antioxidants. But what happens once the body comes under stress, either some infection or inflammatory mechanism, then there is the development of oxidative stress. That is, what happens is the oxidants increase and the antioxidant starts to come down. So that is when the oxidative stress increases, and that is causing damage to the cells and the tissues. Then what are these oxidants? Why we are worried about oxidative stress? If our body constantly reacts when we breathe, it reacts with oxygen and our cells produce energy. Okay, as a consequence of this activity, certain reactive molecules are produced which are having unpaired one electron, that is called as free radicals. And these highly reactive unpaired electron bodies, they are actually capable of causing more of damage to the tissues. So then, and these unpaired electrons, they are highly reactive chemical entities, and they actually try to become stable by either accepting or donating an electron. Okay, so that is called as the free radicals, which can cause tissue damage. The examples of free radicals can be divided into two categories. One, the reactive oxygen species, which will be importantly talked in the present talk. Other is the reactive nitrogen species. The examples of reactive oxygen species, otherwise called as ROS, is hydroxyl ions, superoxide ions, hydrogen peroxide, peroxyl, singlet oxygen, hypochloric acid, and ozone. And on the reactive nitrogen species, what is called as RNS, they comprise of nitric oxide, nitric dioxide, peroxy nitrate, nitroxyl anion, dinitrogen trioxide, nitrous oxide, etc. Then once we talk about oxidants, let us now talk what are antioxidants, that is which impair the harmful effects of the oxidants. Again, antioxidants can be divided into enzymatic scavengers or non-enzymatic scavengers. The enzymatic scavengers can be, examples are superoxide dismutase, catalase, glutathione peroxidase, thioredoxine, peroxyredoxin, glutathione transferase. Non-enzymatic scavengers are all trans-retinol 2, ascorbic acid or vitamin C, alpha-tocopherol, beta-carotene, and glutathione. Among all these, we are interested today in glutathione. Now, if you see the relationship between oxidative stress and antioxidant enzymes, see on the left-hand side, what you are seeing is the superoxide ion. Superoxide ion, which is a free radical, which is harmful, is activated by the enzyme superoxide dismutase, and it produces hydrogen peroxide, which again itself is a free radical, and it causes oxidative stress. So this hydrogen H2O2 is broken down by the enzyme catalase to harmless water and oxygen. Similarly, the hydrogen peroxide, by the action of enzyme glutathione peroxidase, produces water and oxidized glutathione. This oxidized glutathione is again acted upon by glutathione reductase and forms the reduced glutathione, which has a very, very potent antioxidant. And this also changes the cycle from NADPH, which is the reduced form of nicotinamide adenine dinucleotide phosphate, to NADP. So it is again, to summarize, it is the reduced form of glutathione, which is having a very potent antioxidant activity. So how was this glutathione produced? The common entity which is required for the synthesis of glutathione is cysteine. Cysteine is itself derived from various enzymatic processes from methionine, homocysteine, etc. Then cysteine undergoes an enzymatic cleavage by glutamate cysteine ligase and forms gamma glutamyl cysteine, which when acted upon by the enzyme glutathione synthetase actually produces the reduced form of glutathione, otherwise called as GSH. This is again responsible by the enzyme glutathione peroxidase to convert the hydrogen peroxide to harmless water. Okay, now this is how, to summarize, it is cysteine which is the basic ingredient which is responsible for the production of glutathione, which is a very potent antioxidant. Now this cysteine can be provided externally also by our N-acetylcysteine. That is the advantage of this drug. So by creating cysteine, it again progresses to the production of glutathione. So then with this, let us now see, with this background of oxidative stress, oxidants, antioxidants, let us see the role of antioxidant or oxidative stress in COPD patients. So oxidative stress markers in COPD patient were studied in the exhaled breath. This slide will show us, on the left hand side, you are seeing that there is a significantly high level of oxidants like MDA, which are found in moderate and severe COPD patients. And they have an inverse correlation with the FEV1. What I mean to say is, as the volume of the oxidants like MDA are elevated in the exhaled breath of COPD patients, there is a reduction in the lung function. So more the oxidants, less is the lung functions. That is a inverse correlation between MDA rising and the fall in FEV1. Then significantly elevated levels of hydrogen peroxide and 8-isoprostane were found in both stable COPD patients and also unstable COPD patients. So we must understand that though the COPD patient looks stable, but internally it undergoes the elevation of the free radicals. And also this was subdivided into smokers and non-smokers. So if you see the slide on the right hand side, the healthy non-smokers, the level of exhaled 8-isoprostane is less, whereas healthy smokers, by virtue of smoking itself, this free radical is generated and these levels are found to be increased. And COPD who are ex-smokers but have COPD, they also have significantly elevated level of 8-isoprostane free radical, and also in the current smokers. So smoking is a common factor which elevates or increases the value of these free radicals, that is 8-isoprostane. Then the significantly elevated leukotriene B4 and 8-isoprostane were also found not only in stable COPD but also during COPD exacerbations. So if you see the slide on the left hand side, it tells us which controls, it gives us a comparison between the controls and the COPD patients as far as leukotriene B4 and 8 is concerned. It was found that leukotriene B4 is elevated immediately, that is 2 weeks after the exacerbation, which persisted for 2 months after the exacerbation. Similarly, 8-isoprostane level was also found to be elevated in the first 2 weeks, and this elevation of the free radicals persisted for 2 months, suggesting that this free radical damage in COPD exacerbation continues. With each exacerbation of COPD, the free radical production increases, the damage continues for a longer time, up to 6 to 8 weeks as well. Then a study was done to now we have shown that the free radicals are increased, but what happens to the levels of glutathione, which is an antioxidant, which is supposed to counter these free radicals? it was found that in severe COPD and very severe COPD, there was a significant drop in the concentration of reduced glutathione to the tune that it was 89% in severe COPD and only 52% in very severe COPD when compared to stable COPD. So there was a drop in the antioxidant and rise in the oxidants in stable COPD as well as in COPD exacerbation. Having known this, we know that if we can increase the level of glutathione by some mechanism, we can counter this oxidant damage caused by the free radicals, and the oxidative stress can be prevented. So then the N-acetylcysteine was studied, which is a precursor of glutathione. Okay, if you remember my previous slide, I told that this cysteine can be produced by N-acetylcysteine externally. On the left-hand slide, if you see the NAC, that is N-acetylcysteine, by the process of deacetylation produces cysteine. Cysteine, by the enzymatic action of glutamyl cysteine synthetase, produces glutamyl cysteine, and which actin by glutathione synthetase produces glutathione. And this glutathione is a very good antioxidant. Coming on the right-hand side, this N-acetylcysteine or NAC is mainly used in COPD patients since a long time. It has been used mostly for its mucolytic action, because NAC actually disrupts the disulfide bonds in the mucus, thereby reducing the mucus viscosity. It also increases the ciliary beating, and efficacy of the CDI is increased, thereby increasing the mucus clearance. By doing this, it improves the lung functions and controls the symptoms of COPD. This all we are well aware of its mucolytic action. But the NAC has two other important actions as well. One, as you see on the left side, it has an indirect antioxidant action by stimulating the production of glutathione, which is by itself a very, very powerful antioxidant. So it increases the accumulation of glutathione, and also NAC directly itself is an antioxidant by virtue of the presence of the sulfhydryl component. And both the indirect and the direct production of antioxidants clears the reactive oxygen species. That is what we discussed in the beginning, that which is the ROS, which actually causes inflammation. So by reducing the reactive oxygen species, it reduces oxidation and reduces inflammation, thereby reduces mucus production. It also protects the alpha-1 antitrypsin enzyme activity, therefore improving lung functions and controlling symptoms. So this is a very important molecule. It has a direct and indirect antioxidant activity, as well as by the virtue of disrupting of the disulfide bonds, it acts as a mucolytic agent as well. Then this study was done to demonstrate the increased levels of glutathione in the plasma after starting treatment with NAC. If on the left hand side is the group 1, which is the control group without the NAC. On the right, on the group 2 is in between, and group 3 on the right hand side. N-acetylcysteine was given orally in the dose of 600 milligrams per day for 5 days to the two groups, group 2 and group 3. And samples were obtained for measurement of glutathione concentration. In group 2, within 1 to 3 hours, there was a significant elevation of the antioxidant glutathione, which persisted for 16 to 20 hours after the last dose of NAC, as seen in the group 3. So what it shows is NAC was substantially able to not only elevate the levels of glutathione in the early hours, but also the elevation persisted for a longer time. This study was done to show how the N-acetylcysteine reduced exhaled carbon monoxide, which is itself again a very strong free radical and causes oxidative stress. This study was done in India in bus drivers, where the N-acetylcysteine was given once daily and twice daily. So there were 3 groups. Group 1 is the placebo on the left hand side. The middle one is the group 2 with once daily N-acetylcysteine, and group 3 is the twice daily N-acetylcysteine. The blue line is the baseline, and the violet line is after 4 weeks. So exhaled carbon monoxide, when they were measured, it was found that it was significantly reduced after 4 weeks of starting N-acetylcysteine 600 milligrams twice daily. This study was done to see how much there is a reduction in the burden of the oxidants in airways in stable COPD patients with N-acetylcysteine. The measurement was done with hydrogen peroxide. So there were about 50 to 60 clinically stable COPD patients were selected and given NAC. The left-hand side, the orange line, is the baseline when the NAC was started. After 15 days of NAC 600 mg twice daily, the chocolate one is after 30 days, and the last one is after 2 months. And if you see the slide, there is a constant drop in the concentration of hydrogen peroxide in those patients who were given NAC when compared to placebo, where in fact the reverse happened. The H2O2 concentration or the free radical concentration began to increase. So suggesting that N-acetylcysteine significantly reduced the oxidant burdens in the airways of stable COPD patients. With this background of the drug of N-acetylcysteine, the Pantheon study was conducted to know the role of NAC in COPD patients. The Pantheon stands for it was a placebo-controlled study of when the efficacy and safety of N-acetylcysteine high dose was considered in exacerbations of COPD, and the dose of NAC given was 1200 milligrams per day in the form of 600 milligrams twice daily. This was a 1-year study. It was prospective, randomized, double-blind, placebo-controlled trial. Or about 1,000 patients were taken into the study who had moderate to severe COPD, whose FEV1 was between 30 to 70% of predicted. So the two groups, the first group comprised of NAC 600 mg twice daily plus existing therapy as per the guidelines of the GOLD guidelines. Second group was placebo without NAC plus existing therapy. Then they saw the effects of NAC on the efficacy and safety in exacerbations of COPD. It was found that the group with NAC reduced exacerbations in all the COPD patients to the tune of 22%. And when you narrow down and measure the exacerbations reduction in GOLD categorized moderate COPD patients, it was found that 37% reduction was obtained by the NAC group in exacerbation rate in moderate COPD patients. So it has a significant role in reducing the exacerbations of COPD patients. Not only exacerbations, NAC was also found to improve the symptoms in COPD. When the changes were studied as per the St. George's Respiratory Questionnaire, it was shown there was almost double improvement in the symptomatology of these COPD patients. So the conclusion of the Pantheon study was NAC in the dose of 1200 milligrams per day reduces exacerbations in patients with moderate to severe COPD. Number two, it had also enhanced effects, particularly in the moderate type of COPD disease. So after this trial, a post hoc analysis of the Pantheon study was done where evidences of NAC were studied in COPD. And the objective of this study was to determine the influence of smoking and any concomitant medications on the efficacy of NAC in terms of reducing exacerbation. So when the person is smoking or just became an ex-smoker and he on any other medication, to know how much NAC has actually helped in reducing exacerbation. So if you see this slide, this was studied to know the rate of exacerbation by exacerbation severity in the overall population, together with risk reduction. The black one is the NAC group, and the plain is the placebo group. This was mild, moderate, severe, and moderate to severe, and overall exacerbation severities were studied. It was found that in the NAC group, there was a 26% reduction in mild exacerbations, 18% reduction in moderate exacerbations, and if you see overall reduction, 22% of reduction in overall exacerbation. So this is a very important to prevent exacerbations. It's a very good drug. Then it was also studied the rate of reduction of exacerbations in current and ex-smokers. Again the same, the black is the NAC group, the white is the placebo group, and it was shown that in moderate exacerbations, both in current and ex-smokers, there was a 23% reduction in exacerbations in moderate exacerbation group and 23% reduction in overall exacerbations in both current and ex-smokers as well. Another study was done which compared NAC plus any long-acting bronchodilator, that is LABA, NAC plus LABA without inhaled corticosteroids. And the second group was placebo plus LABA plus ICS. Okay, so NAC plus LABA without ICS, placebo plus LABA with ICS. And it's shown again, the black one is the NAC group and the white is the placebo group. It was shown that in the NAC plus LABA group without ICS, there was a 60% drop in overall exacerbation rate, 64% drop in moderate exacerbation rate, and very high 88% drop in severe exacerbation rate. So overall, it was shown in the conclusion of the study was that NAC could be used to reduce COPD exacerbations risk as an add-on to LABAs, long-acting bronchodilators, in particularly as an alternative to inhaled corticosteroids. So the inhaled corticosteroid, what we are concerned about the side effects of long-term ICS can be taken off if a NAC is added to LABA, which is very, very significant in the long-term management of COPD. So NAC was also found to be especially beneficial in both current and ex-smokers, who actually represent the largest proportion of COPD populations globally. If you see most of the COPD patients, in spite of telling them to stop smoking, they either continue to stop or they form, they continue to smoke either as usual in the earlier stages or they reduce the smoking. But most of them are continuing to smoke some cigarettes as well. So in such patients of smokers who are having COPD, also the NAC was found to be reducing exacerbations without the use of inhaled corticosteroids. So much so that this time the Gold 2020 report also showed that in COPD patients not receiving inhaled corticosteroids, regular treatment with mucolytics such as N-acetylcysteine may reduce exacerbations and modestly improve the health status. This is a very, very significant point they have made this time, and they have included N-acetylcysteine as one of the drugs to prevent significantly and to reduce exacerbations. So then the studies were done to know the role of NAC in the management of exacerbations. Now we have talked about stable COPD. Now we are talking about the acute exacerbation of COPD and what is the role of NAC in this. In a single center study, it was a prospective interventional study where patients with ACOPD were admitted, and they were both they were current smokers with 10 or more pack years per year. And the NAC was given in 600 milligrams twice daily in one group, another group was without NAC. So 25 were with NAC, 25 were without NAC. And if you see the various clinical and biochemical characteristics of these patients who were admitted for ACOPD, they were studied on day 3 and day 7 of starting the NAC N-acetylcysteine drugs. If you see on day 3 and which on day 7 also, there was a mean P level, PaO2 level was increased, oxygen saturation increased, PaO2 level increased, PaCO2 level begin to come down. Symptomatology also, wheezing was found to be less, dyspnea at rest, dyspnea on exertion, and dyspnea at night, all three were found to be significantly improved by day 7, and the need for nasal oxygen support also was significantly improved. So thereby suggesting that NAC both on the day 3 and day 7 showed improvement both in the clinical symptoms as well as in the arterial blood gas measurements. With this background, studies were done and NAC was also used in exacerbations of bronchiectasis. And this was a randomized controlled trial to study the effect of this drug on exacerbations of bronchiectasis. Adult bronchiectasis patients with at least 2 exacerbations in the past 1 year were selected for the study. About 160 patients were randomized and they were put on NAC 200 milligrams twice daily for 1 year. And the primary endpoint which was studied was the incidence of exacerbations occurring in a year in these patients who were put on NAC. If you see the slide, the red is the control group without NAC and blue is the group with NAC. it was shown that the incidence of exacerbations in the N-acetylcysteine group was significantly lower than in the control group. It was 1.3 versus 1.98 exacerbations per patient per year. Okay, so the time to first exacerbation in patients receiving N-acetylcysteine was significantly better. Coming to the time to second exacerbation in patients receiving N-acetylcysteine when compared to the control group was also found to be significantly better in the NAC group. And then the parameters were studied at the end of the 12th month from baseline, both for the control as well as on the NAC group. If you see the parameters, the CAT score improved significantly in the NAC group. 24-hour volume sputum production in these patients of bronchiectasis got reduced. Their inflammatory markers like ESR and C-reactive protein were reduced, were improved. And the incidence of Pseudomonas aeruginosa infection, which was found to be frequently positive in the control group, was also reduced in the N-acetylcysteine group. And there was an overall improvement in the lung functions as well. So the NAC was found to be much useful even in bronchiectasis exacerbations. So we have talked about NAC in COPD, we have talked about NAC in smokers and COPD, on healthy smokers as well. We have talked about ACOPD and the role of NAC, and we have talked about bronchiectasis. Now let us go to the viral infection. The studies were done on the role of N-acetylcysteine on viral replication and the production of pro-inflammatory markers. It was found that NAC actually inhibits the H5N1 virus replication and also H5N1 induced production of inflammatory markers. Therefore, it was found that antioxidants like N-acetylcysteine represent a potential additional treatment option, that could be considered in the case of influenza A whenever there is an influenza A virus pandemic. So this drug not only reduced the virus replication but also reduced the formation of inflammatory mediators. Another study was done and published in the Journal of Medicine, which the aim was to compare the effect of adding N-acetylcysteine to conventional treatment versus conventional treatment alone. And the parameters studied with oxidative stress, inflammatory factors, and radiological changes in community-acquired pneumonia patients. And it was found that the plasma levels of free radicals like MDA and tumor necrosis factor decreased more in the NAC group than in the non-NAC group, suggesting that the addition of N-acetylcysteine improves oxidative stress and inflammatory response in patients with community-acquired pneumonia. It was then a study was done again and published to know the objective of this study was to evaluate the effect of long-term treatment of NAC, that is about 6 months, on influenza and influenza-like episodes. Okay. It was found that NAC treatment was well tolerated and resulted in a significant decrease in the frequency of influenza-like episodes, severity, length of stay in bed, and even the clinical improvement. So both local and systemic symptoms were sharply and significantly reduced in the NAC group. Then NAC was also tried with this background in respiratory distress patients. There were 4 trials reported on the duration of ICU stay in patients with ARDS. And it was this meta-analysis showed that NAC treatment significantly shortened the duration of ICU stay when compared with that in the control treatment group. You see all the trials on the left hand side, they actually favor benefit with NAC. Though the 30-day mortality was not reduced, but the length of ICU stay was significantly reduced with NAC, thereby avoiding any ICU related complications and infections. With this background on influenza infection, NAC was studied in SARS-CoV-2 infection, the present pandemic going on. If you go back to the basic mechanism of how the virus attaches, we know that the spike protein of the SARS-CoV-2 virus attaches with the cleaves to the ACE2 receptors of the human lungs, and this cleavage, where there is a bonding between the spike protein of the virus and the ACE2 receptor, this strong bonding is responsible for the penetration of the virus into the cell. So what does NAC do? N-acetylcysteine has been found to bind with the spike protein of the virus, and if you see the initial slides what I told you, this NAC has a very potent activity of reducing the disulfide bond. So the reduction of disulfide bond with the production of thiol derivatives, what it does is it results in a threefold weakening in the binding affinity of spike protein of the virus with ACE2 receptors. The binding of the virus to the ACE2 receptors is significantly weakened, so the virus entry into the cell is significantly reduced. This is done by the antioxidant activity of the N-acetylcysteine. This slide is important, I feel, because if you see most of these categories, the elderly people, more than 65 years, we know that the levels of endogenous glutathione are progressively declines with age, and there is also a decreased biosynthesis of glutathione. In patients with chronic diseases, including diabetes mellitus, obesity, cardiovascular disorders, chronic lung diseases, liver disease, all these patients have deficiency in endogenous glutathione. In smokers, again, we have seen that cigarette smoke depletes the cellular levels of glutathione pool in the airways. And again, the levels of reduced glutathione are lower in males when compared to females. So all these groups, one thing in common is they have a glutathione deficiency. That is why these groups are very prone to develop all the complications of the coronavirus. What does the glutathione deficiency do? It increases the virus replication. It increases the oxidative stress or oxidative damage to the lung caused by the virus. And it also produces more of pro-inflammatory cytokines, causing hyperinflammation and resulting in cytokine storm, ARDS, and death. So it is the glutathione which has to be improved in some way. This chart tells us about the hypercoagulable state persisting in COVID-19 and the role of NAC in these patients. This is very important because most of the complications what we see are due to these changes in the coronavirus. If you see the SARS-CoV-2 virus infection, it causes two things. It causes dysregulated immune response or a hyperimmune response, resulting in inefficient clearance of the virus and releasing of various pro-inflammatory cytokines, what is called as excessive cytokines release and creating a cytokine storm. On the right hand side in the green, the SARS-CoV-2 infection also potentially downregulates the ACE2 expression, thereby increasing the vascular injury by the production of pro-inflammatory cytokines. It increases the vascular injury, it increases the platelet activation, it increases the tissue factor production, and it increases the plasminogen activator inhibitor. So all these combined together make the blood more hypercoagulable state. This is the reason why these patients are going into vascular thrombosis or with thromboembolic events in severe cases of COVID-19. And NAC was found to have a significant anticoagulant and platelet inhibiting properties as well. This study was done to find out the thrombolytic effect of N-acetylcysteine on arterial thrombi, and it was found that NAC was found to be a safe and effective alternative to currently available antithrombotic agents to restore the vessel patency after arterial occlusion. So how does this NAC act as an anticoagulant? If you see, we have seen that N-acetylcysteine. So the possible mechanisms of NAC in prevention and treatment of COVID-19. First, we have seen that N-acetylcysteine reduces the binding of the spike protein of the COVID virus to the ACE2 receptors by its disulfide bond action and the production of thiol group. Number one. Number two, this N-acetylcysteine also is known to reduce the inflammation, oxidative stress, and apoptosis caused by the imbalance in the renin-angiotensin system resulting from the binding of the spike protein to the ACE2 receptors. By this binding, there is a dysregulation of the renin-angiotensin system and results in production of more inflammatory mediators, oxidative stress, and apoptosis, which results in production of more inflammatory cytokines like interleukin-6, IP-10, and all these production of pro-inflammatory cytokines is the reason why the patient goes into cytokine storm. N-acetylcysteine, by reducing inflammation, oxidative stress, and apoptosis is actually found to reduce the levels of these pro-inflammatory cytokines and thereby preventing the patient from going into cytokine storm. This case report was published recently where the glutathione was found to relieve the dyspnea associated with COVID-19 pneumonia. It was given in the dose of 2000 milligrams, and it was found that either oral or IV glutathione or glutathione precursors like N-acetylcysteine in high doses and alpha-lipoic acid may represent a novel treatment approach for blocking the nuclear factor kappa beta chain, NFKB chain, and thereby blocking the cytokine storm and respiratory distress in patients with COVID-19 pneumonia. The therapeutic blockade of inflammation in severe COVID-19 was again studied with intravenous N-acetylcysteine, first in G6PD deficient patient where you cannot give hydroxychloroquine, and also in the without G6PD deficients. The parameters studied were the inflammatory markers like C-reactive protein, ferritin, D dimers, then the nuclear NLR, that is neutrophil lymphocyte ratios. And if you see the gray shaded areas here, they represent the intervals of intravenous NAC administration, the initiation and termination of ECMO, which these patients required, are shown by the yellow lines when the ECMO was initiated and blue dots when the ECMO was stopped. And then the display of total and direct bilirubin on the left side. The B is the tracking of the C-reactive protein and ferritin. These inflammatory markers were tracked, and there was a monitoring done of the neutrophil lymphocyte ratio. It was found that there is a significant reduction in the inflammatory markers in patients with COVID-19 who were ended up in ECMO. As seen here in the 9 patients studied with intravenous NAC administration, the CRP was significantly reduced after the NAC. Ferritin was significantly reduced after the NAC. NAC was given from a duration of 2 to 10 days, and the doses of NAC range from 1200 milligrams to as high as 20,000 milligrams as well. And all patients were on ECMO, and if you see the last column on the right side, there was a significant improvement in the patients on ECMO. Most of them were able to be discharged home, suggesting that this intravenous NAC administration is a very, very important drug in breaking the cytokine storm production and improving the overall outcome of these patients. This was an isolated case report which was published in one of the patients with N-acetylcysteine who went into critical condition and started to retain hypercapnia. This patient had persistent refractory hypercapnia after mechanical ventilation, and then by using N-acetylcysteine inhalation solution, the patient's refractory hypercapnia was gradually improved and he was discharged home. This was again to show significant improvement in the lung functions and the radiological clearance occurring after NAC. An isolated case report again was published recently where the use of low doses of hydroxychloroquine and intravenous NAC were studied, and this combination was found to result in noticeable clinical improvement and also a quantifiable reduction in the inflammatory markers as measured by serum ferritin, C-reactive protein, and lactic acid. So not only it caused a good clinical improvement, but also this is documented by significant drop in the inflammatory markers. So I think this is my last slide. What I wanted to show, if you want to understand how does this drug act in the COVID-19, N-acetylcysteine modulates the activity of the innate immune system by controlling the overproduction of pro-inflammatory cytokines at the NFK beta level. This it does by mitigating the cellular damage because it works as an antioxidant by itself, and it also replenishes the levels of the stores of glutathione, which is again a very powerful antioxidant, which are necessary for the protection of the cells during acute injury. NAC also has potential direct and indirect antiviral activity, and it has shown synergy when it is combined with hydroxychloroquine in the treatment of inflammation related to cellular toxicity. These results are documented by the blood parameters here, where there was improvement in the white count. This was from day 0 to day 10. NLR ratio got improved, serum creatinine got improved, and the C-reactive protein was significantly reduced. And there was also a significant radiological improvement in these patients. So I want to summarize my talk here that NAC is a very potent antioxidant, and this has a significant role in COPD, stable COPDs, COPD with exacerbations, acute exacerbations of COPD, then in bronchiectasis patients reducing their exacerbations and infections with Pseudomonas. Also, it is shown in useful in influenza virus pandemics, ARDS patients, and now in COVID-19 patients in preventing the complications of cytokine storm and microvascular thrombosis. Thank you so much for your patient listening. I hope I was able to convey the information. Any questions, I will be glad to answer.